When we think about a building aging, we typically look at the obvious cosmetic wear and tear. Like we expect the paint to peel or maybe a floorboard starts to creak, right?
Right, yeah. The facade gets a little weathered over time.
Exactly. And we understand that as just, surface level degradation. But consider what would happen if the actual foundation, like the internal structural scaffolding and the rebar holding the whole thing together, just silently dissolved over the years.
Well, the building wouldn't just look a few years older. I mean, the entire structure would fundamentally change shape. The weight distribution shifts, walls lean, and eventually it wouldn't be able to function the way it was designed to. It becomes a structural failure, not just a cosmetic one.
Okay, let's unpack this, because today we are talking about a structural change that happens in the human body. And it's a biological shift that is incredibly common, deeply personal, and yet almost entirely left out of everyday medical conversations. Welcome to today's deep dive.
Thanks for having me. This is such a crucial topic.
It really is. And we have a highly specific mission for you today. We are directly answering a really crucial question we received from a listener, which is, can menopause or the loss of estrogen cause the labia to look deflated?
Yeah, and it's a question that brings us straight into the mechanics of what the medical community now calls genitourinary syndrome of menopause, or GSM for short.
Right. And just to set the stage for you, our insights today are pulled from a really robust stack of clinical guidelines. We're looking at data from the NHS, the British Menopause Society, various urology consensus statements, and even aesthetic surgical resources.
Exactly. And while these physical changes to the vulva can be, really alarming when you first notice them, I want to reassure you that they are a thoroughly documented progressive condition. It's directly tied to the biological withdrawal of estrogen.
So if you are noticing physical changes to the vulva, you are absolutely not alone and you're not imagining it. So let's jump right into the anatomy of that deflation. What exactly is happening mechanically to the vulva when estrogen drops?
Well, to understand the deflation, you have to look at the primary maintenance crew for those genital tissues, because we're talking about a complex area. The labia majora, the labia minora, the clitoris, these aren't static features.
Right, they're highly dynamic tissue.
Highly dynamic, and they require constant metabolic upkeep. So estrogen, along with androgens like DHEA, they are responsible for driving collagen production, maintaining local fat pads, and ensuring a rich, continuous blood flow.
So the estrogen is actively working there all the time.
Exactly. It literally binds to receptors in the vulvovaginal tissue to stimulate hyaluronic acid and keep that mucosal lining thick and healthy.
But then menopause happens, or, perimenopause, or maybe surgical removal of the ovaries, even breast cancer treatments like tamoxifen, and the estrogen just plummets.
Right. And when that systemic estrogen goes offline, the metabolic signaling in the vulva essentially stops. Without that constant chemical instruction to rebuild, the labia majora physically lose their underlying fat pad and their dermal collagen matrix. The actual dermal layer thins out.
So if I'm picturing this mechanically, it's almost like a grape slowly turning into a raisin. The labia majora are losing their internal water retention and their scaffolding, right? That collagen and fat.
That's a perfect analogy, yeah.
So they end up looking deflated, shrinking, and sometimes taking on a more pendulous or wrinkled appearance. But is this just happening to the outer lips?
No, that biological withdrawal impacts the surrounding tissue just as aggressively. So simultaneously, the inner lips, the labia minora, can thin out or resorb into the surrounding mucosal tissue. They can even fuse together due to the chronic lack of lubrication and cellular turnover.
Oh, wow. They can actually fuse together.
Yeah, it's a structural fusion. And because the surrounding tissue is actively shrinking and losing volume, the clitoris can suddenly become uncomfortably prominent. Or, depending on how that tissue fuses, it can get completely hidden under a layer of adhesions.
Wait, I need to challenge this timeline for a second, because if estrogen drops across the entire body during menopause, causing immediate, highly visible reactions like hot flashes or night sweats, why does this vulvar tissue breakdown seem to have a delay?
That's a great question.
I mean, why doesn't the labia deflate the exact day the hot flashes start?
It comes down to cellular half-life and tissue density. So vasomotor symptoms like hot flashes, those are immediate neurological responses to estrogen withdrawal in the brain's hypothalamus.
Okay, so the brain reacts instantly.
Right. But the vulva is a dense, multi-layered matrix of fat, collagen, and highly vascularized muscle tissue. It has physical reserves.
Oh, I see. So it kind of coasts on its savings account for a while?
Exactly. It takes time for the existing collagen to degrade and for those local fat cells to fully metabolize without being replaced. And that is why these severe structural changes often take 3 to 5 years post-menopause to fully manifest.
Which means by the time you actually notice the deflation in the mirror, you might be years past your last period, which makes it incredibly hard to connect the two events.
Precisely. The timeline disconnects the cause from the symptom in the patient's mind.
But beyond just noticing a change in the mirror, what does this actually mean for daily life? Because, deflated labia sounds almost strictly like a cosmetic issue.
What's fascinating here is how purely form dictates function in this part of the body. The outer labia, the labia majora, act as a literal physical protective cushion for the highly sensitive internal structures.
They're like biological shock absorbers.
Yes. And when you lose that fat pad and the tissue deflates, you lose your primary mechanical protection.
So the friction of everyday movement suddenly becomes a huge liability.
Immensely. Activities like cycling, horseback riding, wearing tight denim, or engaging in sexual intercourse, they suddenly lack that necessary cushioning.
Which has to be painful. It's severe. That leads to direct friction on the deeper, unpadded nerves, resulting in chronic pain and a much higher vulnerability to physical trauma and micro tears in the tissue.
Here's where it gets really interesting, though, because you can think of the vaginal ecosystem like a perfectly balanced, well-tended garden. And the physical deflation of the labia is really just the visible external wilting. It's basically the fire alarm going off for a massive invisible shift happening inside.
That's exactly right. The internal cascade effect is where the most severe systemic disruptions occur. In a healthy, estrogen-rich environment, the cells lining the vaginal wall are thick, and they are constantly turning over.
Right.
And as those superficial epithelial cells mature and shed, they release a complex carbohydrate called glycogen.
And going back to our garden analogy, the glycogen is the fertilizer, right? It's the food source.
It is the exclusive food source for lactobacilli. Those are the specific protective bacteria that completely dominate a healthy vaginal microbiome.
So lactobacilli consume the glycogen and produce lactic acid as a byproduct. And that lactic acid is what keeps the vaginal pH low, usually between 3.5 and 4.5.
So it's highly acidic.
Very acidic. It's an environment specifically designed to be hostile to outside pathogens.
But when you turn off the water supply, when the estrogen drops, the vaginal walls thin out. The cells stop shedding that glycogen, so the protective plants, the lactobacilli, literally starve to death.
They do.
And when the good plants die, the weeds aggressively take over the garden.
Exactly. Without lactobacilli producing lactic acid, the vaginal pH rapidly rises above 5. It becomes alkaline. And a pH above 5 is the optimal breeding ground for commensal bacteria, particularly E. coli.
E. coli, like from the digestive tract.
Yes, E. coli naturally migrates from the nearby gastrointestinal tract. So the external structural deflation is actually mirroring a complete bacterial takeover on the inside.
The physiological chaos of that is just wild. You have mechanical friction on the outside from the lost fat pads and an E. coli overgrowth on the inside.
Which results in the hallmark debilitating symptoms of GSM. We're talking severe vaginal dryness, intense burning, abnormal discharge, and profound urinary tract dysfunction.
Because the thinning affects the urethra too.
Right, exactly. The tissue thinning affects the urethra just as much as the vagina, leading to urinary urgency and frequency. Patients experience recurrent, really aggressive UTIs because of that alkaline pH and the E. coli colonization.
And the really tragic part of this timeline is that women often go to the doctor for these urinary issues, right? But because they are 3 or 5 years post-menopause, the doctor misdiagnoses them with overactive bladder.
Happens all the time.
They get put on bladder medication when the root cause is actually vaginal tissue atrophy.
Along with the misdiagnoses, there's the physical constriction to consider. The vaginal opening, the introitus, can narrow so significantly without estrogen that it develops stenosis.
Stenosis meaning it shrinks.
Shrinks dramatically. Clinical guidelines actually define this severe narrowing as an opening restricted to the width of fewer than 2 fingers. It makes basic gynecological exams, let alone intimacy, totally excruciating.
So what does this all mean? I mean, if we are looking at a biological cascade that structurally deflates the outer anatomy, alters the entire microbiome, and narrows the internal anatomy to the point of severe pain, why aren't we talking about this?
It's a huge blind spot.
Right. If nearly 90% of any demographic experienced a structural and functional breakdown of a major organ system, wouldn't it be front-page news? Is this just societal embarrassment keeping everyone quiet?
This raises an important question about how the medical establishment fundamentally views and prioritizes menopausal care. I mean, yes, societal embarrassment is a massive hurdle, but the failure is largely clinical.
How so?
Well, estimates show that anywhere from 13% to 87% of postmenopausal women experience these symptoms. Yet, the data reveals a stark reality. Only around 7% to 25% actually seek treatment.
That is a staggering gap.
It is. And it's because clinicians rarely initiate the conversation. They just don't proactively ask about painful intercourse or vulvar changes during routine physicals.
And because they don't ask, patients assume it isn't a real medical issue. They mistakenly believe that, shrinking labia, pain, and chronic dryness are just the inevitable, untreatable tax of getting older.
Right, they think it's just part of aging.
So they're left to self-treat inappropriately with over-the-counter moisturizers that don't address the biology at all. Or they simply endure it, which heavily impacts their sleep quality, their self-esteem, and obviously their intimate relationships.
We really have to contrast this with how we treat hot flashes. Vasomotor symptoms are widely recognized, they're easily discussed, and critically, they eventually fade out on their own as the brain adjusts to the new hormone levels.
Right, the hot flashes eventually stop.
But GSM is the exact opposite. Tissue atrophy is chronic, it is progressive, and most importantly, it is entirely irreversible without direct intervention. Tolerating this silent epidemic doesn't build resilience. It actively leads to worsening sexual dysfunction and permanent vaginal stenosis.
So the whole grin and bear it approach is actually physically damaging.
Absolute.
But let's look at the actual protocol for a patient who decides, not to tolerate it anymore. Where do they start? Because there is a highly effective rejuvenation toolkit available, ranging from lifestyle modifications all the way to complex regenerative surgery.
Well, the baseline clinical recommendation usually starts with mechanical stimulation. Regular sexual activity, which can be penetrative or non-penetrative, solo or with a partner, physically stretches the tissue.
Okay, so keeping the tissue active.
Yes, this mechanical action stimulates blood flow to the pelvic region, which brings oxygen and vital nutrients to the cells, helping to maintain some baseline elasticity. And pelvic floor exercises achieve a very similar goal by drawing muscular blood flow into the genital region.
Right, and alongside the mechanical side, there's the topical management. Non-hormonal lubricants and daily moisturizers, using brands like, yes, Silk or Liquid Silk, can artificially replace the lost mucosal hydration. But there is a very specific clinical caveat when choosing these products over the counter, right?
Yes, this is crucial. Patients must read the ingredient list carefully, specifically looking for parabens. Parabens are very common preservatives in cosmetics, but they act as endocrine disruptors.
Meaning they mess with hormones.
Right. They have mild, weakly estrogenic properties. Now, for the general population, this might be negligible. But for someone with a history of hormone-dependent cancers, like estrogen receptor-positive breast cancer, introducing unmonitored estrogenic compounds into highly permeable vulvovaginal tissue poses an unnecessary risk.
Wow, okay. So mechanical stretching and paraben-free moisturizers make up the lifestyle tier. They manage the symptoms, but to actually halt the physical deflation and reverse the root cause, you have to reintroduce the missing chemical messengers.
Exactly. Vaginal estrogen is the clinical gold standard here. It comes in low-dose creams, tiny dissolvable pessaries, or a slow-release silicone ring called an S-ring that just sits in the upper third of the vagina for 3 months at a time.
Oh, that sounds convenient.
It is.
Yeah.
And the crucial mechanism here is local delivery. It binds directly to the estrogen receptors in the vulvovaginal tissue, rethickening the cells and kickstarting that glycogen production we talked about earlier. And it does this without significantly raising estrogen levels in the systemic bloodstream.
Which is why it's often prescribed even for patients who are contraindicated for full-body hormone replacement therapy, right? Because it works right at the site of the problem.
Exactly.
There is also a secondary hormonal option that involves vaginal DHEA. And the mechanism for this is almost like biological alchemy.
It really is incredible. DHEA is a prohormone. When a patient inserts a vaginal DHEA suppository, the actual compound is inactive.
Wait, inactive?
Yes. But the enzymes living inside the vulvovaginal cells absorb the DHEA and synthesize it intracellularly, meaning entirely inside the cell, into active androgens and estrogens.
That's amazing.
It does its repair work, boosting collagen and restoring the acidic pH, and then gets inactivated before it ever leaves the cell. So it's a localized, completely self-contained repair mechanism.
But even with local estrogen or DHEA restoring the mucosal lining and the microbiome, hormones alone sometimes can't bring back the massive volume loss in the outer labia, can they? I mean, once that fat pad is fully metabolized, it is gone.
That's correct.
And that brings us to the most advanced tier of intervention. To fix the deflation of the outer cushion, we enter the realm of aesthetic and regenerative surgery. Specifically, a procedure called gynecological fat transfer, or labia puffing.
I know it sounds like a purely cosmetic vanity procedure, but given everything we just discussed about the labia majora acting as a necessary physical shock absorber, replacing that lost volume has profound functional and mechanical benefits.
The mechanics of the procedure are fascinating. Surgeons use microliposuction to harvest the patient's own fat, usually from the abdomen or the inner thighs. They put that fat through a centrifuge process to isolate the viable cells, and then they inject it directly back into the deflated labia majora.
And it is vital to distinguish this from temporary hyaluronic acid fillers. Some aesthetic clinics offer HA fillers for the labia, similar to what is used in facial contouring, but the body naturally dissolves those within 6 to 9 months.
Right, so you'd have to keep doing it.
Exactly. A fat transfer operates on a completely different biological principle.
Because once the transferred fat establishes a new vascular network, once it hooks up to the local blood supply, which takes about 3 to 6 months, it is permanent living tissue. But I need to dig into the cellular biology of this, because by taking fat from the stomach and putting it in the vulva, you aren't just stuffing the deflated area to make it look plump again.
No, not at all.
The clinical data suggests you are actively transplanting a regenerative repair kit. How does stomach fat heal vaginal atrophy?
If we connect this to the bigger picture, we really have to change how we view human adipose tissue, or fat. It isn't just inert yellow padding. When surgeons process the harvested fat in the centrifuge, they're isolating something called the stromal vascular fraction.
Okay, the stromal vascular fraction.
Yes, and this fraction is a concentrated biological powerhouse. It is packed with mesenchymal stem cells, endothelial progenitor cells, and T regulatory cells.
So you are injecting pure regenerative fuel into an atrophied environment.
Precisely. When the stromal vascular fraction enters the damaged, thinned-out labia, it promotes angiogenesis, which is the creation of brand new blood vessels.
Oh, wow.
It also triggers neocollagenesis, literally forcing the body to lay down a fresh, thick matrix of collagen. It doesn't just push the skin up from underneath. It actively remodels the local biology. It softens old microscar tissue from years of friction, it dramatically improves local hydration, and it thickens the dermal wall.
That is just phenomenal. Regenerative medicine is completely blurring the lines between cosmetic aesthetics and functional gynecology. I mean, to go back to our grape and raisin analogy, the fat transfer doesn't just pump the raisin full of water so it looks like a grape again.
Right.
The stem cells actually heal and thicken the skin of the grape itself, restoring the fundamental structural integrity we talked about at the very beginning of the deep dive.
It permanently gives a woman her protective cushion back, utilizing her own biological material to reverse years of chronic tissue decay.
So, to synthesize everything we have unpacked for you today, yes, to answer your core question, estrogen loss absolutely causes the labia to deflate, thin, and drastically change shape. But this is not a shallow cosmetic quirk of getting older that you just have to quietly tolerate.
No, it is the visible hallmark of genitourinary syndrome of menopause. It alters your cellular biology, it starves your protective lactobacilli, it forces your vaginal pH into an alkaline state, invites aggressive bacterial colonization, and causes real physical and mechanical damage to your body.
But you are armed with a massive amount of clinical knowledge today. Whether you choose to boost your local blood flow with pelvic floor exercises, or rebalance your microbiome and tissue thickness with local estrogen delivery, or even utilize a stromal vascular fat transfer to permanently restore your mechanical shock absorbers, you have powerful, highly evolved options.
You really do.
You do not have to accept discomfort, pain, or deflation as an inevitable, untreatable part of aging.
The clinical tools are readily available. The cellular science is proven and highly advanced. The absolute most important step in this entire process is simply breaking the societal silence, recognizing the symptoms for what they are, and demanding the precise medical care your body requires to function.
Absolutely. And we want to leave you with a final thought to ponder today. We just explored how the stromal vascular fraction inside our own relocated fat holds a regenerative power to literally reverse the chronic biological decay of menopause in our most sensitive tissues. It rebuilds blood vessels and collagen from scratch.
It's incredible.
So, if moving our own fat cells can functionally heal a deflated, failing organ, What other inevitable aging processes might we soon be able to cure just by moving our own biology around? If the structural scaffolding of the building starts to fail, maybe we don't need to look outside for synthetic materials to fix it. Maybe we've had the ultimate repair kit inside us all along.